Well, hello, everybody, and good evening, and welcome to Eaglet Eye's VIP webinar Module 1. We're delighted to have tonight Jason Jedlicka. He is going to walk you through the contents of Module 1. We're going to go over some basic scleral lens information, nomenclature, some fitting strategies, and things like that. Module 2 will feature the next step up, and then Module 3 will dig deep into profilometry. So without further ado, I'm going to introduce our program director, Dr. Tom Arnold from Houston, Texas. So Dr. Arnold, welcome. It's your show.
Thank you very much, Tom. It's a pleasure to be here. It's a very honor to be the course manager with these esteemed colleagues of ours. Very, very happy to be here with Jason Jedlicka tonight. And what we're going to discuss is profilometry-based scleral fitting. And the goal of this is to help everyone get more comfortable with the concept of scleral lenses, some of their challenges, and how profilometry can make that fitting process faster, more precise, and give you and your patients better results and get to that endpoint a lot quicker. So Module 1, as we said, we're going to cover the basics of scleral lens fitting with someone that I've known for a very long time, Dr. Jason Jedlicka. And when I first started fitting scleral lenses a few years ago, I ran across some webinars and some papers from Dr. Jedlicka, and I've learned a lot from him and consider him one of my major mentors in this journey. So a little bit about Jason. He is the associate professor at Indiana University School of Optometry, where he's the director of the Cornea and Contact Lens Service. And he has so many accolades and awards. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technologies. He's the past president and one of the early presidents of the Scleral Lens Education Society, and a fellow, of course, and a past board member of the Contact Lens Society of America. He has contributed to multiple textbooks on the topic of scleral lenses. In addition to that, he is the developer of ZenLens and the ZenLens RC, and as such is now a consultant to Bausch & Lomb. And again, Jason, it's wonderful to have you, and it's a privilege to be here with you. So please take it away.
Thank you so much, Tom and Tom. I appreciate the opportunity to take Module 1 and run with it here and introduce scleral lens basics, and in particular, as we go through this, to introduce profilometry and its increasing role in the efficiency of scleral lens fitting. Today, Module 1 topic will cover why sclerals. We'll also talk about the great unknown, and that is the shape of that sclera that we're fitting the lens to. We'll talk about how to best assess the sclera. There's lots of ways we can assess shape, some much more convenient and efficient than others. And then we'll go into a little bit of the basics of scleral lens fitting, but I'm going to save a lot of the more exciting scleral lens fitting concepts for our future modules. So again, first topic, why sclerals? Well, you know, what is a scleral to begin with? Before we talk about why, let's introduce what we're talking about. A scleral lens is a GP lens which is fitted to vault over the cornea and limbus and to land with its full bearing on the sclera and conjunctiva. The true benefit here, of course, is that we get the optics of a GP lens, but we don't have the issues of GP comfort or contact with a potentially fragile cornea. The liquid reservoir, which is held underneath the scleral lens, bathes the eye, keeps it healthy, hopefully, and preserves, again, the corneal epithelium from rubbing against a lens that might cause some long-term problems. A scleral lens can be easily considered to be three different zones: an optical zone, which is the central vault area, moving out to the very periphery, our haptic zone, or the landing area, the scleral zone, if you will. And then between the two, we have a transition zone, which brings that vaulting area back in contact with the eye and blends out into the landing area. In order to fit a scleral lens, we want to make sure that each of these three zones is fitted properly for the best possible results. Just a few terms to go over to make sure we all speak the same language. The things that we talked about when we fitted corneal GPs, we have some different terms when we fit scleral lenses. The first one is our SAG, or our sagittal depth or sagittal height, all really referring to the same thing. And this is simply the depth or height of our lens from apex to edge. We can also refer to the sag of the cornea, which would be the height or depth of the cornea from at a given chord diameter, which we would choose. There's also limbal clearance, and this is the space between our lens and the limbal region of the eye. We want to ensure that the lens doesn't crash down with pressure on the limbus, as it's a fragile tissue. That's very important. But again, we don't necessarily want or need excessive amount of space there either. So this is an area of delicate balance of clearance without excessive clearance. There's also the scleral zone, or the haptic, as we mentioned. And this again is the part of the lens that is designed to rest on that ocular surface. We can talk about different geometric shapes for any contact lens, but specifically for a scleral lens, we talk about prolate or oblate shaped lenses. And this is simply lenses that have a similar shape to a normal cornea, or prolate, where the back optic zone is going to be steeper and then it increasingly flattens towards the periphery. Alternatively, an oblate design, which is going to have a flat central zone and then steepens before it returns to flattening again in the periphery. These are different types of geometric shapes to best accommodate the various types of eyes that we're going to fit with a scleral lens as we do scleral lens fittings. We also can talk about microvaults or edge vaults, and these are localized areas in a lens that have a specific curvature to vault up or over landmarks or elevations on the eye. These are often on the sclera, like a pinguecula, but they can also be corneal nodules that are very protruding, and we can create areas where the lens can rise up and avoid excessive pressure in a focal spot. We can also talk about a notch, which is an area of the lens which has been removed by careful sculpting of the edge of that lens to allow for an area to move around an obstacle. So instead of vaulting up over it, a notch will move around an obstacle. And this again avoids undue pressure on one spot that can cause irritation, again, instead of going up over it, by going around it. And then a final term to talk about that we'll use frequently when we discuss scleral lens fittings is compression or blanching. And this is simply referring to a situation where the edge of the lens puts too much pressure in one area focally without enough distribution of pressure. And you'll often notice that blood vessels will be compressed or restricted or cut off by that lens edge because of a focal area of compression or area of landing. Again, when we remedy that, we're simply going to try to redistribute the bearing over a broader area to relieve that compression or blanching. We can also talk about some different types of scleral lenses, and as we get better technology, we can do more things with our lenses to better fit the variety of eyes, again, that we might face. We talk about lenses mainly in the haptic or the scleral zone being spherical. And again, this is a situation where each individual curve of that lens is spherical all the way to the edge. This is historically how we fit scleral lenses years ago, but as we have broader lathing technology and diagnostic technology to show us about the shape of the eye, we find ourselves moving increasingly towards torics, where we create height differences between the two principal meridians of our scleral lens. We also can talk about something called a bi-elevational scleral lens, and this is when we create two different sagittal heights within our same lens, not just strictly in the scleral zone, but introducing elevation differences internally into the part of the lens that vaults the cornea to best land that lens as evenly as possible on the sclera. We can also create quadrant-specific scleral lenses. Again, the scleral lens, as you'll see, has quite interesting array of shapes that can occur. And so Just like with corneal lenses, we sometimes need torics or quadrant specifics. Much more so even with sclerals do we benefit from these types of designs. So a quadrant specific lens is one that's going to have a different set of shapes in each of the 4 quadrants of the lens. And then again, as technology allows, we are creating some truly customized and freeform lenses that are made to truly conform to even the most irregular eye shapes through multiple zones of curvature. So why sclerals? What are the intended purposes? Sclerals really have 2 different distinct purposes in managing eye care, managing ocular conditions. One is to restore or improve vision, and this can be for irregular cornea patients, patients with scarring or keratoconus or corneal surgical patients, etc. And the benefit there again is to give them GP quality vision without touching that cornea. The other intended purpose of a scleral can be to shelter an eye that's compromised. So our patients with ocular surface disease, where they have a hard time opening their eyes are so sensitive to light and so uncomfortable all the time due to their disease process, that scleral lens can shelter that eye and allow the cornea to be protected from the outside world that's damaging it. And so when we can do both of these things, and that often is the case where ocular surface diseases go hand in hand with irregular corneal shapes, in those cases we're really seeing scleral lenses shine the brightest, and that is when we can both protect the ocular surface and correct the vision better than we could with other means of correction. There are other advantages of sclerals. The comfort matter, no corneal touch, little or no movement, tucks well behind the lids. Patients just can note, again, better comfort with scleral lenses than many other lenses. I've had many patients over the years where I've fitted them in a scleral lens in one eye and a soft lens in the other because of a variety of reasons. And it's not unusual for a patient, once they've adapted to their lenses, to say, could I please get fitted with a scleral lens in this eye that has the soft one, because not only is it equally comfortable, in many ways I find it easier to work with. There's also larger optic zones with scleral lenses than corneal GPs, so we can often get better quality of vision without issues with glare from a small optic zone lens, especially for our keratoconic patients. Again, no corneal distortion. The lens doesn't touch the cornea. It doesn't create warpage. We also see longer wearing times for many of our patients, and the stability issues with scleral lenses where they stay put on the eye, they don't shift or pop out. Patients, again, who have worn corneal lenses for years and get refitted into sclerals often say, it's strange because I feel like I can look back and forth now without worrying about whether my lenses will stay put. And that's just relieves stress and tension in their lives every day. So the indications for scleral lens, as we mentioned, we have our group of corneal ectasias such as keratoconus, keratoglobus, pellucid marginal degeneration, post-LASIK ectasia. These are all patients that have focal thinning, and then because of that focal thinning, they have focal elevations on their cornea. That causes visual disturbances, and traditional ways of treating it, like corneal lenses, often can create issues of comfort and epithelial health issues for these individuals. So this is a prime category of scleral lens wearers. And we can see again the shape of that keratoconic cornea lending itself to blurriness, but when we put a scleral lens over the top of it, we create a normal optical shape for the eye. We then also have our post-surgical category, and these can be post-LASIK or PRK, post-refractive patients that simply have residual refractive error or some astigmatism that's developed over time, and they just prefer contact lens correction, but fitting them with a soft lens just doesn't work because of the shape of their eye. The lens is unstable, and it can change in shape with each blink, and so scleral lenses often provide these patients a more stable, better visual outcome. Similar for our post-RK patients. Again, these folks often have irregular astigmatism due to their corneal shape, and so the scleral lens can give them better quality of vision. As well, our post-RK patients can have corneal fluctuations where their prescription can literally change from morning to evening. And with a soft lens or glasses, we don't see a stabilization of that effect. But with scleral lenses, where the lens holds its shape and allows the cornea to change under it, we can stabilize people's visual quality through the course of the day. And then again, our post-graft patients, transplants are another significant group of individuals. Even as their corneas are often in better shape from the front to back, they also have high degrees of astigmatism, and using GP lenses often helps give them better quality of vision with a much more manageable prescription. But again, stability, comfort with a scleral lens for those post-graft patients who can tolerate scleral lenses, they often are a go-to for them as well. And then our next category again of patients are those dry patients. Patients who suffer from chronic staining, which leads again to visual issues for those folks. We put them in scleral lenses not so much to treat their dry eye, of course, but to manage the corneal effects of dry eye, as well as to alleviate their symptoms, even as we continue to manage their dry eye condition concurrently. And we have a whole host, again, of ocular surface diseases where the dry eye component can be moderate to severe, and we have a lot of other corneal pathology that creates irregularities such as dystrophies, degenerations, trauma, etc. All of these individuals are prime candidates, again, for scleral lenses. And finally, refractive error. Is there any reason why some of these individuals can't wear scleral lenses? I have some patients who are high astigmats that had worn corneal GPs, bitorics, and became more intolerant of the comfort. I have patients who have high degrees of astigmatism that have issues with lens stability and rotation. And again, these folks can often benefit from and appreciate the stability of vision that they get with a scleral lens along with the comfort. And so again, as we think about all the wide variety of patients between irregularities and scarring and dryness, etc., we find that scleral lenses have a growing place in many of our practices because our patients' reaction to them is so positive, and we see the benefits in our individual patients' lives. So let's move on to talking a little bit about scleral shape, because ultimately that's a big part of the success for scleral lenses, is to get a lens that fits to the scleral part of the eye properly. It's relatively easy to create a lens that completely vaults the cornea and limbus. It's much more challenging to properly align the scleral zone or the haptic to the sclera as optimally as possible. We know that what influences the shape of the sclera, at least in part, is the insertion of the extraocular muscles. And so as we look around the eye, we see that different muscles have different locations on the eye and exert different influences over the shape of the eye. We also know from studies that the shape of the eye closer to the limbus is more regular, but as we move peripherally, especially beyond 15 millimeters, irregularity and asymmetry absolutely increase. There's also a wide variety of limbal shapes, and this transition from the cornea to the sclera is a delicate area that we really want to make sure we fit properly, but we don't always know this shape just to look at an eye with a slit lamp or to look at it with a corneal topography, because it doesn't give us that information. The geometry through the limbal zone is not always curved. I think we often, when we draw our little pictures of eyes on a sketch something out, we're looking at maybe number 3 or number 4 on your diagram there is how we would draw it. But the reality is that there's a more gradual or linear relationship through the limbal zone than we would expect. And so image number 2 is actually the most common transition zone through the limbus for our patients. Again, as mentioned a moment ago, this was a study published in 2017 at a cohort of 12.8, which is actually the area where many scleral lenses kind of hit their landing point, where they come down on the eye initially. The eye is nearly rotationally stable. So that's good news. That means that if we're going to build in toricity into the internal aspects of a lens, we should be able to achieve a good landing. However, again, as we move out further and further, 15 millimeters and beyond, definitely more asymmetric. And our nasal segment generally has flatter scleral shape, and our temporal and inferior temporal zones with a steeper scleral shape and different types of transitions. So this is important to be aware of. We did a study a few years ago at Indiana too, looking at corneal topography and trying to correlate it to scleral shape. Could we use corneal topography to somehow predict scleral shape? And of course, as we found from our study, there was no strong correlation between corneal shape and scleral shape. However, the one thing that came out of this was a recognition that in general, without statistical significance, we know that scleras are far more against the rule in shape than corneas. Against the rule, corneas make up a very small percentage of corneal shape, but against the rule, scleras probably comprise a good 30 to 40% of scleras. So there is this transition as we move from the cornea to the sclera where the shape is changing and it increases in its amount of change and its against the rule rotational change in shape the farther and farther we go into the periphery. And is that due to the extraocular muscles? Perhaps. But as we've looked at, especially those patients with irregular corneas, like keratoconus, for example, how does that type of corneal shape affect our scleral shape? And what we find that is, as our cornea becomes increasingly irregular, so again, those patients that are our most common patients to fit in scleral lenses, the sclera actually becomes even more unpredictable and asymmetric. So while it's possible that if we look at a normal corneal shape, we might be able to make some prediction of what the sclera might look like. As again, we move into more irregular corneal shapes, we find that that predictability becomes basically thrown out the window. So the steeper the anterior cornea, the more asymmetric the sclera, the more off-center the scleral or the corneal apex, again with patients with, say, keratoconus, with more decentered apex, the more the sclera has a quadrant-specific or irregular profile. So we know that, again, our corneal topography is difficult to correlate to any type of scleral topography, and in particular for those patients that are most commonly fit in sclerals, those with irregular corneas have the least amount of predictability and crossover between corneal shape and scleral shape. As we look at corneal shape and scleral shape, again, we can see a wide variety of scleral shapes. These are bisphere elevation maps, and I'll explain a little bit more about what that means in just a moment from the eye surface profiler. But as you look to the left, you can see a spherical cornea, as you can tell by the corneal topography part of the map, that merges into a relatively spherical scleral shape as well. As we move on to the second picture, we can look at our corneal part of our map and see a high degree of corneal toricity that also does blend into a highly toric sclera. As we move into patients with, say, central keratoconus in our central picture, we see now a very much an increasingly irregular scleral shape. Very steep at the bottom of the sclera, much more elevated above at 1 to 2 o'clock, and then again over at 9 to 10 o'clock. So we have focal areas of elevation, focal areas of depression without much of a pattern. Again, our next patient, a pellucid marginal degeneration patient, a very inferior thinning, we see again a highly irregular scleral shape. And in our post-surgical eyes, we can see not only a irregular oblate-shaped cornea, but we then also gain some irregularity to our sclera in those patients as well. So studies have been done to, again, look at scleral shape and try to categorize it for our benefit as we fit individuals with scleral lenses, and using a fairly broad or wide range of what's an acceptable amount of variation in shape, up to 300 microns in difference across the scleral surface, considered spherical. We see that literally only 5 to 6% of individuals would be categorized as having a spherical scleral shape. Now, much more scleras are toric. We can see that regular toricity comprises almost 30%, but even that is not that high a percentage. When we look at the most common types of scleral shape, we see quadrant-specific effects. Again, we notice this in particular with our irregular cornea and ectasia patients, and then just simply irregular shaped scleras. Now, it's entirely possible, given a lack of experience or availability of quadrant-specific designs or freeform designs, that many of our quad-specific and irregular scleral-shaped patients do better in torics than they do in spheres. However, as we have moved more of our patients towards toric scleral lenses, we'll probably find, as technology shows us the way and better lens technologies available as well, that we are increasingly moving patients to more customized lenses like quad specifics or multi-zone lenses, because truly that's even more common again than regular toric eyes. Again, toricity on an eye can have all sorts of different orientations. We can see on the far left a very typical with the rule cornea with a very with the rule sclera. However, we move to our central picture and we see a mildly with the rule cornea with an against the rule sclera. And we do see this being not uncommon, that corneas that are closer to spherical, low with the rule corneal shapes often end up with oblique or against the rule scleras. So you can't use that corneal shape necessarily to predict anything about the scleral shape. We can get oblique toricity. In my mind, when I think about toricity on a sclera, I would almost consider that with the rule scleras make up 1/3 of patients, oblique cylinder or oblique toricity patients make up 1/3 of scleral eyes, and against the rule toricity makes up about another 1/3 of our patients in terms of scleral shape. Again, we know that much more individuals have with the rule toricity in their cornea, but moving to the sclera, oblique and against the rule toricity become much more common and probably almost as common as with the rule shape. We also know that our sclera is filled with these irregular focal elevations. Pinguecula are very common. Pterygium are not that common, but still are seen in patients who are going to potentially wear scleral lenses. Surgical blebs or scars from retinal surgery, for example, can also create focal areas of elevation that when we want to fit these individuals with a scleral lens, we don't always know how those focal elevations will affect our fit. And we're putting diagnostic lenses on, and sometimes we can be very far off in our fit when these elevations are high. It's very difficult to know that when we put a notch or a microvault or edge vault in a lens to accommodate one of these, how is that going to change the rest of the fit? So again, profilometry, as you can see in the pictures on the right, showing us the impact of a filtering bleb or pinguecula, where we can actually measure the height and look at the scleral tissue around these areas of focal elevation, can be very helpful in streamlining the fitting process and helping us to get a better fit more quickly. So again, just to conclude our quick assessment of scleral shape, does the cornea give us enough information for fitting scleral lenses? Well, it helps a little bit. Again, we certainly need to know the size of the cornea we're fitting. It doesn't hurt to know the shape of the cornea to best get our vaulting area in good alignment to that shape, but it's really not adequate. It really requires much trial and error to get the scleral aspect of our fit right. Can we predict the scleral shape by assessing the cornea, especially in our irregular cornea patients? I think the answer is certainly no. So again, can we use scleral shape data to improve fitting success rates, especially for complex eyes? We certainly can. And better data will definitely reduce the fitting curve. So moving on to assessing the sclera, we want to talk about the ways that we can actually gain information about the shape of the sclera. other than scleral topography. There are ways that we can get data about the scleral shape. We can certainly use our slit lamp to get some information, particularly once we have lenses on. We can certainly use OCT to give us information about the scleral shape, and corneal topography, again, can give us a little bit of limited information, potentially, about our scleral shape. Again, putting a diagnostic lens on an eye and just looking at how it fits, and again, as you see in the picture here, where maybe in the vertical meridian we've got a fairly decent alignment, but in the horizontal meridian we have a significant amount of edge standoff, it's pretty easy to interpret from this fitting relationship of our lens to eye that this individual has an against the rule scleral shape. The problem is that we had to put a lens on the eye that doesn't necessarily fit very well to figure that out. And so again, it's a time-consuming process. And then even as we find out, gosh, we've got this against the rule scleral shape, I need a toric lens, and I put a toric lens on, how close will that actually be to the patient's amount of toricity they have? There's a limited number of lenses I can actually put on that eye out of my diagnostic set to tell that. So again, the slit lamp does give us opportunities to look at scleral shape when we've got a lens on eye. When we see things like edge lift, compression from a tight fit, impingement, all of those things are going to give us clues that this sclera is either toric or irregular. And so it does help us a little bit. Is it the most efficient way of doing it? Clearly not. If we have better ways to obtain that information, it's more helpful. But if you don't have access to the data, you can figure this out with effort. So how about using OCT? Well, historical OCTs, if we go back 10 or 15 years, we could certainly use OCT to give us SAG data for an eye and potentially even some shape data if we wanted to take a number of scans and look at maybe several scans one after the other to try to look at that transition zone of our limbus and the steep or flat curvature of our sclera in each meridian. But honestly, most OCTs now are moving away from these broad views where we can get a 15 millimeter data cord. Most of our OCTs now are moving towards smaller, more high resolution sections at a time, which don't really help us in the fitting process when it comes to picking an initial lens. OCT can give us limbal shape information as well, and so again, this can be helpful, especially as we're looking at a scleral fit, but most of these situations are going to occur once a lens is already on the eye, not necessarily in helping get us to our initial lens. Again, modern OCT has a limited view of the ocular shape. As we move towards smaller sections of data, better resolution, we find that in order to actually look at the shape of the eye, we need to take many scans and somehow piece them together, and the time is more cumbersome in many ways than it would be even put on a diagnostic lens and look. So OCT is very helpful in evaluating ocular shape relative to a lens that's on the eye, but independent of having a lens on the eye, it's very difficult to use OCT in our initial fitting process. Again, as mentioned earlier, how does corneal topography help us? Well, it certainly can help us get corneal data, and so it will help us to understand, do I need a prolate or oblate shaped geometry in order to get a better, more even alignment or vault to the cornea? It can also give us corneal diameter data to help us pick a proper scleral diameter that we ensure will land past the limbus. And again, the severity of the condition. If we have a very steep cone versus a mild cone, that's going to give us a little bit of SAG data, at least in terms of making our best guess at an initial diagnostic lens. And that's true, but however, again, corneal topography really gives us no scleral shape data, so we can't assess the need for the best type of haptic, whether it might be spherical, toric, quadrant specific, etc. It's just not enough data so that when we put a lens on, we're having to basically start from scratch in assessing the scleral shape relative to that diagnostic lens. So corneal topography is certainly useful in fitting a lens if that's all you have. It does help you get a better fit than if you don't have that information, But again, you're really on your own when it comes to evaluating the sclera. You don't get that information from your corneal topography. So how does profilometry make this process so much more straightforward? Again, we're getting tens or hundreds of thousands of data points, not just on the cornea, but on the sclera and limbus as well. You've got height maps to assess the shape of the eye. You've got elevation maps, angle maps, etc. It's going to show you, again, whether your eye is generally spherical, regularly toric, irregular shaped, and again, as you move towards either diagnostically fitting a lens or empirically ordering a lens, either way, it's going to make that process much more straightforward, and you're going to be able to get patients fitted with lenses with far less diagnostic lenses needing to be placed on the eye. And in our COVID world we live in, that's great. And in the guidelines we have for disinfecting lenses, we just don't have the time anymore to be putting lots of diagnostic lenses on patients if we're fitting more than one patient in a day. So let's talk about the eye surface profiler, how it works. It is a camera system with two different light projectors. It's going to give us a roster type information about the eye in a grid shape, as you can see by the second image. You see this detailed grid that is reflected off the eye that comes back to the instrument to collect that shape data. And then it can create literally a 3D height profile from these data points. All this is done with a single measurement without stitching or extrapolation. You're getting true measured data on each of our patient's eyes. This is, again, what the instrument looks like. I'm going to go ahead and run through. We've put fluorescein in our patient's eye. We simply pull the lids apart. We align our dots in the center. We align our dots to the side. We capture, and we've got our image. We can take multiple images. Sometimes, typically we'll take 3 or 4 images. I'll let the patient blink between each one to redistribute the fluorescein, and you can capture them within a matter of 20 or 30 seconds. You could capture 5 or 6 images that you can have to go back and assess for consistency and look for quality of your images. Again, just looking again at our capture process, we're aligning the central dots to the red dots, we're aligning the 2 little snowballs to the right, and we're casting the different reflections across the shape of the eye to give us that feedback of the true height data. When we get a height map, what we can see is our general absolute height map doesn't give us a lot of information about the shape of the eye because it's the cornea and the sclera are all run through on the same reference. And so it looks like a fairly generic map. We don't see a lot of great information from our height map, but it is true data, and it is apples to apples if we ever wanted to compare. Now, most of us have grown up working with corneal topography, and we're used to looking at curvature maps, and we certainly can get a curvature map from our profilometer as well. And the tangent angles map really is kind of that look. It's showing us the rate of curvature change over the surface of the eye. And so this is more of the look of a true corneal topography like we might be used to. However, it does have application, in particular looking for, if we want to look for, again, a lens imprint like you see on the far right side, if we want to look for localized areas of change that are subtle, sometimes looking at a tangent angle map can be very helpful. We often see things like the nasal flattening on the picture on the left versus the non on the right. Can be a little bit harder to detect occasionally on an elevation map. And so again, using the tangent angles map as you gain more experience with profilometry can be helpful in getting a second perspective on the eye shape we're looking at. However, in general, the bisphere elevation map, which is what you see on the right, is the most useful tool for assessing scleral shape. This again is giving us height data of both the cornea and the sclera, but it's doing it on 2 different reference spheres so that we can get an optimal look at the shape of the cornea and a separate optimal look at the shape of the sclera. So when you look at this, you might say, well, gosh, what is this red zone between the cornea and the sclera? Is it really that steep right in that area, or is it really that flat in there? And the answer is no, not really. You have to recognize that our cornea and our sclera are being presented to us on different reference spheres. So we want to consider them and look at this map considering the cornea and the sclera independently, and not try to take this entire picture, this single picture, as one unit picture. It's really two different images in one, giving us corneal data as well as scleral data. And you can see by the picture here on the right, we're getting a lot of shape data for our sclera up to, looks like about 17, 18 millimeters with a single scan. And we can see a beautiful look at a pinguecula on the right side of our picture. When we look at a bisphere elevation map, we want to recognize that the red areas are more elevated, they're closer to us, and so these red areas, because they're higher, the shape change is slower, and so these are actually the flatter areas of curvature change, but they're higher areas of elevation. So the picture on the left, our toric with the rule eye, this basically indicates to us our horizontal meridian of our sclera is higher, it is less curvature or flatter in shape, and our vertical meridian, that's deep blue, is farther away from us, and therefore to achieve a farther position from us, it has to be bending at a faster rate or steeper in curvature. So if we were to place a toric scleral lens on the picture on the left, on that eye, what we would find is the flat meridian of the scleral lens would align horizontally, and the steep meridian of the scleral lens would align vertically. We can see that same effect on these other types of eyes. We can see a toric against the rule eye shape, where our flat meridian would probably orient about 70 or 80 degrees. We can see the impact of a pinguecula, or double pinguecula, or irregular shapes. So this bisphere elevation map really helps us truly understand the shape of the sclera that we're trying to fit, and whether we can get by using a spherical lens, a toric, or whether we need to move into something more customized, quadrant specific or freeform, simply with a glance at our map. It gives us so much diagnostic information to help derive the type of lens we want to fit on our patient. So let's talk quickly about the basics of scleral fitting. As we approach scleral lens fitting with or without scleral shape data, there's really a three-step process, and we want to think inside out. The first thing is we want to get proper central clearance and ensuring that we've chosen the proper diameter. So when we look at a corneal shape and size and understanding what's going on with our patient, whether it's an advanced cone or a post-graft, all of those things would allow us to theoretically put a lens on the eye, look at our central clearance, and see if it meets our general guideline for what we expect or what we want for central clearance, whatever that might be. Generally speaking, when I fit a scleral lens, when I first put a lens on the eye, I want to see 250 to maybe up to 400 of central clearance at initial application, knowing that over time I'm going to lose some of that clearance. Ideally, I've got a tighter window, but with my first initial lens, I'm willing to be a little more flexible on that initial clearance and then see what happens over time. We also will try to align to the shape of the sclera by choosing a curvature for our base curve that is semi-close to our corneal shape at least. Now that's not to say that if we have a very steep cone that we want a very steep base curve, but we don't necessarily want to be so radically different in shape from our cornea that we end up with areas of excessive clearance or inadequate clearance over any part of the cornea. So again, as we fit a lens, we want to completely fit to the cornea, get corneal clearance, completely vault the cornea, whatever that desired amount is. And if we put a lens on the eye that's inadequate vaulting or excessive vaulting, we simply can change to a lens with more or less sag. The next thing we look at as we move out is that first landing point. Do we have limbal clearance? Does our lens land on the eye at the initial landing point beyond the limbus? Is it landing on the cornea or limbus? or is it landing so far beyond the limbus that we're going to get issues with conjunctival tissue being accumulating underneath our lens? So these are both pictures of not good fits. The picture on the left showing limbal bearing over a large part of our lens. The picture on the right showing excessive limbal clearance, where you can see the limbus being drawn up into the back of that lens. So again, we would want to adjust potentially the lens diameter, going larger on the left picture or maybe going smaller on the picture on the right. We also, as we learn more about fitting scleral lenses and are getting better at it, we want to sometimes check the sagittal height difference at, let's say, a 13 millimeter chord length, or whatever the landing area of our lens should be. In many cases, we'll find that patients have a difference in the sagittal height at that first landing point, and sometimes it's helpful to build toricity into the limbal zone of a patient's lens in order to get the lens to properly land on the sclera at that initial landing point, and then continue to maintain that alignment over the entire surface of the scleral zone. So again, once we've got a lens on eye that's got reasonable corneal vault, that reasonably fits the limbal zone where we know we've got the right diameter, we can move out and assess how the lens fits in the scleral zone. Again, as you see by the pictures here, we can see spherical shaped scleras, the far left topography. We can see a very regular against the rule scleral shape in our middle topography. And on the right, we have a patient with a quadrant-specific effect where the inferior quadrant is much steeper than any of the other three quadrants. When we put lenses on eye, we'll often see that. We will get compression, like we see the picture of the two pictures, the one on the left, where we see compression and harsh blanching in the horizontal meridian that's causing injection of that scleral conjunctival tissue. This is clearly a situation where we need to move to a toric or more toric haptic than we already have. Again, the picture on the far right, we see a lens with edge lift horizontally. This is indicating, again, we probably need a toric haptic on this patient's eye. We just didn't know that until we put a lens on eye, unless we had scleral data, scleral profilometry information to understand that prior to placing lens on the eye. Again, it's really helpful when we've decided the diameter of lens we want to work with to take our sagittal height data box in our map. There's so much data that we have available to us as fitters, and to put in there whatever chord length we choose, let's say 15 millimeters if we're fitting a 15 millimeter lens. And the instrument will tell us the sagittal height difference at 15 millimeters. It will tell us how much toricity we need to build into our lens in microns, in this case 170 microns of toricity. And again, as we look at the potential need for quadrant-specific lenses, we can look at our temporal sagittal height versus nasal sagittal height factor, as you see on this box on the right, which shows a 600 micron difference in temporal sag versus nasal sag, which is a clear indicator anything above 400 microns would benefit from a quadrant-specific lens. So all of this data is readily available through our profilometry data cells. So just to wrap up for tonight, this introduction to the concept of understanding scleral shape, some basics of scleral lens fitting, understanding how to interpret profilometry. I want to just broach to you the two basic approaches to fitting scleral lenses today. One is with your fitting set. And with your fitting set with no scleral data, but just simply maybe a corneal topography and your diagnostic set, you can certainly get a scleral lens fit on a patient's eye. We did it for many years. This was the best we could do. However, the process can be cumbersome. You often have to put on 2, 3, or even 4 lenses in office to find something that approximates a good fit, and then you still need to refine your fit from that point and hope that your first ordered lens is dispensable. So again, that process can be cumbersome both to your office in terms of chair time, as well as to our patients who have to have multiple lenses put on their eye to get to that point. We also have to deal with disinfecting lenses. And again, these lenses are supposed to soak for 3 hours in peroxide after each use. Do you want to tie up your diagnostic set that long? And again, living in this COVID, maybe hopefully post-COVID world that we're moving towards, we still have the concern that using diagnostic lenses over and over again is less desirable for our patients. So the alternative is what we call an advanced empirical lens fitting process, and that is when we acquire reliable corneal and scleral shaped data from a profilometry. We use that data and the first lens fit software that's incorporated in our profilometer, in our instrument, to help to know the proper lens sag and toricity, and to come up with almost an ideal fit based off the patient's corneal and scleral profilometry. And then to take that information and to go ahead and order a lens that is made for that patient, and so that when that patient comes back, the one and only, hopefully, lens they're going to put on at that appointment is one that is brand new and is made for them. And that's going to be a better fit in most cases than anything we would put on out of our diagnostic set. So our patient's first experience with a scleral lens on their eye is going to be a relatively close fitting lens. It's going to feel better. It's going to be much closer for them to an ideal fit. And so again, maybe dispensable, maybe not, maybe require a little bit of adjustment to the prescription or fit. But again, our patient's first impression is going to be positive, and we're going to be using a new lens for that patient. And again, you can either order this advanced empirical lens using some known patient data, depending upon their previous prescription in lenses or in refractive error. It can be, or you can just simply order your initial lens as a plano lens, letting the patient know that the first lens may need to be adjusted for prescription. But the point again is that we don't have to wait for a lens to disinfect. We know our lens for our patient that first visit when they come in, and simply have profilometry done, and off the lens order goes. Very quick, very easy. They come back in a week or two for their lens, and again, it's a lens that's made for them. And again, that's still going to be a diagnostic lens in theory, but that first diagnostic lens is going to, again, be much closer to the patient's ideal lens fit. So with that, I will turn this back over to Tom to take us through the last few minutes of our webinar.
Well, thank you, Jason. That was excellent as always. And I always learn something from you, which is why I've followed you for all these years. And we started off with the question, why do we do sclerals? And I think most everybody who are joining us tonight probably are involved in some degree of fitting sclerals, or they soon will be. And we all know, those of us who do this, know that scleral lenses really do change lives, not an exaggeration. So the more we know about the sclera, the more control we have and the better patient outcomes we will achieve. And that first lens fit, that wow factor that a lot of patients experience from their first scleral lenses, it'll just be, as you have said, Jason, a better fit, a more comfortable fit and healthier for the eye. So along with all these great tools, and they really are great, and it's an exciting time to be in this field of specialty lenses, it is important that we continue to develop our skills. And Jason, you've taught us so much tonight. There are resources out there, and I urge everybody to, if you haven't already, kind of dig in, do a little homework, join the Scleral Lens Education Society. That's free to be a member. There's some excellent downloads that are free from the GP Lens Institute. Dottie Fidel and Melissa Barnett's excellent book, The Scleral Success. Afe Vanderwarp's classic book, sponsored by Bosch and Lomb now, The Guide to Scleral Lens Fitting. And then, of course, I want to invite everybody to the International Congress of Scleral Contacts. This will be our 5th annual meeting. I have the privilege of being a co-chair of that meeting along with Dr. Melissa Barnett. It'll be in Fort Lauderdale in July. And of course, Contact Lens Spectrum always has great articles. And I invite you to join or visit the Eaglet Eye Academy, where you can get a lot more information on the eye surface profiler. And so please join us for our next seminar on May 27th, same time, 8 p.m. Eastern time, where Dr. Barry Leonard from the Los Angeles area will join us and take a deeper dive into the more specialized, more challenging aspects of fitting scleral lenses and how profilometry can help you achieve that. All right, so super. Thank you very much, Jason. Thanks to the Eaglet Eye personnel. I think there's one more slide with maybe some references, but thank you for joining us. And here's the contact information for more information from Eaglet Eye. I know they love to hear from you. Thanks again, Jason. It was really great. Appreciate your time.
Thank you.